So good evening, everyone. So before I start, I would like to thank Dr. Ravi Doshi sir and the whole CCI team for giving this opportunity. So the topic that has been allotted to me is what a pulmonologist should know about lung cancer in 2022. So as we know that the November month is celebrated as the Lung Cancer Awareness Month, and the reveal color for this specific tumor is white or pearl color. So you have allotted me 15 minutes. I have a 15 message that I would like to convey all of you in this 15 minutes. So without wasting time, I would like to start with the first message: know your enemy better. So this is the Globocon 2020 data, which suggests that in year 2020 there is around 1 crore 92 lakhs cases of cancer were diagnosed. Out of this, around 11.4% of the patient has lung cancer. If we see in the male, we can see the male are affected slightly more, around 14.3%, while in female it is around we can see it is around 8.4%. So what is surprising in Globocon 2020 data that the percentage of cancer lung cancer patients in female is increasing. If we see the incidence versus mortality, we can see the incidence of breast and prostate cancer is much more than the lung cancer. But if we see the mortality, the death, we can see lung cancer is still on the top. So it is a deadly disease. So once we know that this is a deadly disease, do we have any role of screening? So this is message number 2. In We have US Preventive Service Task Force recommendation, which suggests that adults aged 50 to 80 years who have around 20 pack year smoking history and currently either smoking or have quit the smoking within last 15 years should undergo a screening with low dose CT scan yearly basis. So this is the detailed recommendation. I will not go into the detail of this recommendation. So what is low dose CT scan? So as compared to the conventional CT scan, the low dose CT scan for lung use approximately 5 times less radiation. The radiation exposure with low dose CT is around 1 to 4 millisieverts as compared to the conventional CT scan, where the exposure dose is around 5 to 20 millisieverts. The amount of radiation patients are exposed during low dose CT is approximately equivalent to receiving 15 traditional chest X-rays, taking 50 cross country flights, and around 6 months of natural background radiation. So this appears to be very safe. What is the data for screening? So the data comes from the National Lung Cancer Screening Trials. The article was published in New England Journal of Medicine in 2011. So you can see that when you have low dose CT as compared to the chest X-ray, this modality is not only picking the more number of lung cancer patients, but it is also able to decrease the death due to lung cancer by around 20%. So this is, I think, we can follow, but we should have a dedicated separate unit for this screening. Lesson number 3: tissue should not be an issue. So as we know that we have come a long way where the non-small cell lung cancer is considered as a one disease, then it is subdivided into squamous cell carcinoma, adenocarcinoma, and now we know the adenocarcinoma part specifically had divided into different subtype based on specific mutation. So for accurate diagnosis, you require 4 additional tests. First is morphology, that is the histopathology that will confirm the disease. The second is immunohistochemistry, especially to know whether my patient is having a squamous cell carcinoma or adenocarcinoma. Third is molecular testing. With the help of molecular testing, we will come to know whether my patient has any genetic mutation or not. And last is the PDL1, so as to assess eligibility for immunotherapy. So I want to do at least these 4 important tests to know the accurate diagnosis. And for all these tests, I require tissue, rather a lot of tissue. So these are few of the following points that I would like to convey on all of you. We should never ask for FNAC. We should always try to do biopsy. While taking biopsy, we should always try to take multiple cores, and we should ask our pathologist to make at least 2 separate blocks so that one block can be used in in-house testing, and second block we can send for further molecular testing. Please make the touch imprint. After taking biopsy, do not put the biopsy material directly into the formalin. Put on a glass slide, roll over the glass slide with the help of another glass slide. And so question is why it is important. Why it is important to make a touch imprint? So I will give an example. For example, I have a female coming with severe back pain, on evaluation found to have bony metastasis and lung as a primary. So we have to start this patient on palliative radiation as soon as possible. But one until we have a biopsy report, no one will start on radiation. And even for applying for Ayushman, you require a biopsy reports. Or by getting a biopsy report usually takes time, at least 2 to 3 days. And so we in some cases we cannot wait for 2 to 3 days. And the result of touch imprint will be available in few hours. So apart from taking biopsy, sending biopsy in formalin bottle, always take a touch imprint. The third next important message is we should stop asking for pleural flow cytology. We should ask for pleural flow cytology and cell block. Every time you are making a cell block, you are generating a tissue, and tissue is very important for me. Discuss with the pathologist. So assume that you have a female patients where the biopsy is suggestive of non-small cell carcinoma. Your pathologist is not able to differentiate whether it is squamous or adeno. Now, if the tissue is small, she or he should tell you and call you and ask whether you want to go for IHC or molecular testing. So when I have a non-smoker female, I'm not interested to know whether it's a squamous or adenocarcinoma. I am more interested to know which type of mutation, which type of genetic mutation my patient is having. So I think there has to be very fine coordination with the pathologist. The second is the importance of repeat biopsy on progression. So assuming I have a EGFR positive patients, I have started on gefitinib. After 1 year, patient is progressing. In these cases, to know the mechanism of progressing, I need again rebiopsy. So once I send a patient's known case of CL lung for rebiopsy, most of the time I want to know what is the mechanism of progression. Staging. Knowing the staging is very important. So this is the TNM classification. I don't want you to go into the details. I have taken few of the diagrams to understand the staging in a simple, relatively simpler manner. So stage 1 is the disease is confined to the one lobe. Stage 2 is the disease is confined to one lobe, but you can see the size is more, around 4 to 5 centimeters. This is 2A. In 2B, you will get some hilar node. Stage 3A and B and C. And 3A, the tumor size is more than 7 centimeter. In 2B, you have ipsilateral mediastinal lymph node, and 3C, you will have ipsilateral supraocular lymph nodes. Then stage 4 is further divided into 4A and 4B. In 4A, you will have pleural nodules, all malignant pleural effusion, and 4B, there should be a distant metastasis. I know it appears confusing, but when you practice in day-to-day basis, it's real simple. Now coming to the message number 5, the role of PET scan. So we have discussed what is required for accurate diagnosis. Now we need to accurately stage the patient, and for accurate staging of lung cancer, I need the assessment of the primary tumor, I need the assessment of regional lymph node, I need the assessment of distant metastasis. And when I say distant metastasis, I need to evaluate for liver metastasis, adrenal metastasis, lung metastasis, bone metastasis, and even the brain metastasis. Unless I have the detailed information of primary tumor, regional lymph node, and distant metastasis, accurate staging is not possible. And for doing all these, you require the CT scan of neck, thorax, and abdomen with bone scan and even MRI brain. So we can replace all these investigation with a single test PET scan. Nowadays, PET scan is now I think easily available in most of the cities. And so once the pathological diagnosis of lung cancer has been made, I think the only investigation which I would recommend is the PET scan. The drawback of PET scan that sometimes it is not the not accurate investigation to assess the disease in the brain. So in some cases, the MRI brain is required along with the PET scan, but even the large brain metastasis can be easily picked up with the help of PET CT. The message number 6, no assumption, prove it. So we know that every carcinoma in the lung is not lung cancer. Radiological features are more important, especially the speculated mass, the associated mediastinal lymphadenopathy, I think the most important feature. But we should not assume. If you have 1% doubt, do not assume, prove it. Especially in the patients who has prior history of any cancer, now coming with solitary or multiple lung metastasis, then we should always rule out the previous cancers. Like if I have a breast cancer patient coming with solitary pulmonary metastasis, I will 100% rule out that this primary is not from the previous cancer. So how to rule out? So we have to do ISC. What is ISC? ISC nothing is simple test where we put the antibody on the tissue. If against the particular antigen, if that particular antigen is present, the antibody will fix with the antigen and it will produce a brown color. So this is how it is good. Like after the biopsy, the pathologist will divide into small cell or non-small cell, and non-small cell into adenocarcinoma, squamous cell carcinoma. In around 20 to 25% of the patient, our pathologist will not be able to differentiate between adeno and squamous, and now they will write non-small cell lung cancer polydifferentiated. Once it is polydifferentiated, it is important to know whether it is adenocarcinoma or squamous cell carcinoma. In these cases, we need to apply immunohistochemistry. So the name of 3 ISC marker we all need to remember: the P40, TTF1, and nepsin. The P40 is positive in squamous cell carcinoma, TTF1 and nepsin in positive in adenocarcinoma. So for example, you have a tissue where you have positivity for TTF1 and nepsin, but negative for P40, it is nothing but adenocarcinoma. Another patients, you can see there is negative staining for TTF1 and nepsin, but P40 is strongly positive, is nothing but squamous cell carcinoma. There will be some occasionally, all the 3 markers are positive, there the diagnosis is adenosquamous. So apart from the squamous, adeno component is also there. So P40, squamous cell carcinoma, TTF1 and nepsin in adenocarcinoma. The message number 7, treatment after staging. So the accurate treatment, the optimal treatment for lung cancer require multidisciplinary discussion, which is the key to success, especially in stage 1 to 3. So this is the treatment schema. I know it is very simplistic, and this might not be the accurate representation of the treatment, but I want to simplify. So for stage 1 and stage 2, it is the surgery followed by chemotherapy. For stage 3, it is radiation plus chemotherapy, that is chemoradiation. For stage 4, it is systemic therapy. The palliative care is very important. It has to offer to stage 1 to stage 4 patient, even if like someone is suffering from stage 1 lung cancer, if it's coming with pain, definitely I have to take care of the pain. So palliative care is very important irrespective of the stage. Now coming to the message number 8, the treatment modality available. So there are local modality, local therapy. In local therapy, we have surgery and radiation. Again, in the radiation, we have EBRT and SBRT. The next speaker will deal with surgery and radiation in greater detail. Apart from local therapy, we have systemic therapy. In systemic therapy, we have chemotherapy like carboplatin, pemetrexed, gemcitabine, and so on. Immunotherapy like pembrolizumab, nivolumab. We have monoclonal antibodies like bevacizumab, ramucirumab, and then comes the oral drugs, the tyrosine kinase inhibitor. For each of the mutation, you can see there are specific oral tablets are available. For example, for EGFR, we have erlotinib, gefranib, osimertinib, dacomitinib, and afatinib. So discussion after this slide is applicable for only for stage 4 and SCLC. So the message number 9, find the target gene. So who are the patients who are the ideal candidate for molecular testings like EGFR, ALK, ROS1, and on. So all the non-squamous histology patients like adenocarcinoma, adenosquamous, large cell carcinoma, or other rare histology, all these patients should be tested, are candidate for molecular testing. Now, the second category is all the non-smoker patients, irrespective of histology. If they are non-smoker, especially female, should also be tested for EGFR, ALK, or ROS1, and so on, the genetic mutation. So now, how to find the target gene? So this is message number 9. So we have two approach. One is Hanumanji type of approach, which is the test name is next generation sequencing, and other is non-Hanumanji types, where we will be testing for each targetable gene one after the other. So we know, especially in the adenocarcinoma, it is a heterogeneous disease. We have to check for n number of genes. It is literally not possible to check for one gene after the other, because it requires lot of tissue. And also, if we test for 10 genes, the cost is also a limiting factor. So we should always go for multi-gene panel, that is next generation sequencing. But there are some disadvantages, like the availability. NGS test is not available. I am fortunate that in my institute I have NGS machines. Complexity, you need a special person to analyze the data. The cost is also a big constant, and the turnaround times, it takes around 2 to 3 weeks to get the results. So when the NGS is not possible, the non-Hanumanji type of approach is also very simple. So with the help of company coupons, the genetic testing for EGFR, ALK, and ROS1 is almost free of cost. And before considering for chemotherapy or immunotherapy, we have to check at least for EGFR, ALK, and ROS1, because we know that these three mutations are most common one. Other mutations are less than 1 to 2%. Coming to the message number 10, find the suitable drug. If the target gene is positive, choose the drug wisely. We know that for the each mutation, we have multiple drugs. For EGFR, we have 5 drugs. So when I say wisely, I have a meaning. For example, if my patient is positive for EGFR, which out of these five drugs I should be using? So there are different factors that we need to consider. So the first factor is disease distribution. So the most important one is the presence of brain metastasis or not. If my patient has brain metastasis, I have to choose a drug which penetrates the blood-brain barrier. So out of these 5, osimertinib is the only drug which are very effectively have activity in the brain. What is the data? This is a phase 3 data from FLORA trial, where the patient's EGFR positive patient was randomized into osimertinib versus erlotinib or geftinib. You can see the better PFS in the patients who received the osimertinib as compared to the patients who received geftinib or erlotinib. The second factor that we need to consider is the affordability. See, the osimertinib is first drug. Everyone cannot afford. So do we have any other regimen which can be as effective as osimertinib? So answer is big S. So this is the phase 3 NAG009 trial, where the patient EGFR positive patients were randomized into geftinib alone versus geftinib plus chemotherapy. And you can see the PFS. The PFS, that is progression-free survival. So what is PFS? From the day of randomization to first progression, this duration will be known as PFS. So you can see the PFS in the patients who received the geftinib is around 11 months, and the patients who received geftinib plus chemotherapy, it is 20.9 months. So almost doubling of PFS. Not only the PFS, the overall survival. What is overall survival? The day of randomization to the death is also increased. Then geftinib arm, it is 38.8 months, while in the geftinib plus chemotherapy arm, it is 52. So almost more than 4 years. And please remember, we are discussing only stage 4 patients. So stage 4 patients surviving more than 4 years is really impressive. The third factor that we need to consider is the performance status, which is nothing but fitness. So this is the toxicity data of the previous trial we just discussed. We can see that 1/3 of the patient has grade 3 toxicity. So what I mean to say that we need to choose the regimen very wisely. And when the patient is positive for EGFR, just writing the geftinib or erlotinib, I think that era has almost gone. Lesson number 11, the immunotherapy is the new hope. We know that in 2018, Nobel Prize of medicine was given to the two gentlemen, the Tokoshi Honjo from Japan and James P. Ellison from USA. And this is the picture how they celebrated in different manner. So who are the candidate for immunotherapy? How to assess? So the ideal candidate for assessment of eligibility for immunotherapy is the all patient with squamous cell histology and all the patient of non-squamous histology without target mutation. And that has to be ruled out with next generation sequencing. All these patients are eligible to receive immunotherapy. Then how to assess? The assessment will come from PD-L1 testing, and this is nothing but simple ISC test. So there are 4 different antibody and 2 different platform. I will not go into the detail of this, but with if you, after the PD-L1, you will have some number that how many tumor cells are positive for PD-L1. If this number is more than 50%, you can very well go ahead only with immunotherapy. If this number is 1 to 49%, we have to combine immunotherapy plus chemotherapy. If this number is less than 1, that is 0%, then we are left only with chemotherapy. These patients will not benefit with immunotherapy. So what is the data? This is the Keynote 042 trial, where the patients, NSCLC patients with high PD-L1 expression, that is more than 50%, were randomized into the chemotherapy versus the pembrolizumab in the dose of 200 milligram every 3 weekly. And you can see the impressive data. The overall survival is much better in the patients who receive the pembrolizumab, that is immunotherapy alone, as compared to the patients who receive chemotherapy. And you can see that the response, the benefit is sustained over a period of more than 5 years. Message number 12, the palliative management. The 2 important palliative management that we can offer to our patients is fluorodesis and pain management. You people are very well versed with fluorodesis, and talc fluorodesis work really fantastic. Where we are lacking is the pain management. So for the pain, we have to follow the WHO step ladder pattern from step 1 to step 2, 3, and 4. All of us, we go for step 1 to 2. Step 1 is nothing but simple paracetamol or combiflam type of drug. Step 2 is nothing but the tramadol like Ultracet. What we are not doing, that we are not escalating to step 3. Step 3 is nothing but a morphine. Every MBBS doctor can prescribe legally morphine. We can start the morphine with 10 milligram 4 to 6 hourly, and it's really wonder drug. The pain disappear once the patient start on morphine. The dose that we are using doesn't cause respiratory depression. The only thing we need to remember that once you start on morphine, we have to also prescribe laxative, because morphine cause constipation. The message number 13, be a part of Tumour Board meeting. The question is, why Tumour Board meeting is essential for cancer patients? So my simple answer that the treatment of cancer patient is not the one-man show. We require multidisciplinary team, especially if resectivity is the concern. So we require pathologist, radiation oncologist, medical oncologist, pulmonologist, and thoracic surgeon, and so on. The list is long. We need to really sit together and discuss each cases so that we can provide the optimal treatment to our patient. The message number 14, the early involvement of oncology department. So even with the slightest suspicion of malignancy, involve the oncologist. It will not only save the time, but it will also save the money by better planning of investigation. Make the standard operating procedure for lung cancer evaluation. It will really help. If the Tumour Board exists in your institute, it is well and good. If Tumour Board does not exist, then at least know whom to consult for a specific patient. So like I'm a medical oncologist. If you send me stage 1 lung cancer, this will be literally a waste of time. If you send a stage 4 cancer to a surgical oncologist, again, this will be a waste of time. So at least know that early stage patients, you can refer to surgical oncologist, especially the stage 1 or 2. The stage 3 patient will need chemoradiation, and the stage 4 patient need a qualified medical oncologist. The last message is the best time yet to come. I am optimistic, and I want to prove this by this phase 3 trial, the ALEX trial, where the ALK positive stage 4 patient, lung cancer patient was randomized into the alectinib versus crizotinib, and this is the progression-free survival. So from the date of randomization, you can see the median progression-free survival is 34.8 months. So almost for the 3 years that my patient will be taking a single tablet. Once my patient progressed after 3 years, I will again do a rebiopsy and I again try to find out what is the mechanism of resistance. Once I know the mechanism of resistance, I can again start on another drug, and the story goes on. This is, I want to end my talk by giving this example. This is my patients presented with the thoracic diseases, and you can see the brain mets is also there, the extensive bony metastasis, started on serotonin 450 milligram with food in May 2019. You can see and the response of the oral drug, and this is the PET CT scan in September 2020, and this is the very recent PET scan. You can see there is almost complete response in the recent PET scan. So I think this is all from my side. Again, I would like to thank all of you for your patient listening. Thank you so much.